So in an overview of what I've kind of done so far, like en route, I went to the Uni of Manchester. I graduated in 2020 and then did my foundation training in the Northwest in Tameside Hospital for 2 years. Then I took a year out and went to New Zealand, did a bit of obs and gynae there, did a bit of other stuff there. And at the end of that year, I came back and worked as an education fellow at Manchester Royal Infirmary, and then applied for obs and gynae training during that year and started in August 2024. So I'm like not even finished S21 yet, but I've been doing it since August last year. So I was asked to kind of go through why I chose obs and gynae and what kind of drew me to the specialty, and then also how I built my portfolio and built my experiences along the way to get into it. And I think like when I was like trying to like separate it, they kind of all merged, and both of them kind of changed over time with the experiences I was doing. So I'll go through kind of how that happened and what I did along the way to help, and try to kind of give you guys top tips that you can kind of do yourself. I realized on reflection, I was looking through it and it looks like I'm just talking about my life for like 20 minutes. So I'm sorry if it sounds conceited. I just found it the easiest way to explain is like as a timeline as to what drew me in and how I ended up getting into training, because I didn't always know I wanted to do OMG. So yeah. So I first thought about wanting to do obs and gynae when I was a fourth year medical student in university. I had a placement at St Mary's Hospital, which is a tertiary centre for obs and gynae in the Northwest. And I was on placement there and I just fell in love with that. I thought it was so cool. There was one registrar, like I'll never forget this like shadowing experience. There was one reg and she had like bright red hair and just like was really cool. And we were on labour ward and this emergency buzzer went off in this woman's room. I had like palpitations. I was like running, like, what? Ran into this room and the whole room on this labour ward was just chaos. Like everyone was shouting, like it was an emergency. I think it must have been a fetal braddy, like a low baby's heart rate. And this reg walked into this room and just spoke so clearly. The whole room went quiet. Like she went to the woman, assessed the situation and got this baby out and just like had complete control of that situation, turned this chaotic environment, which was stressful and scary, into just such like a managed, paced situation, and just got this baby out that was obviously very at risk. And then just like walked out the room. We just went to the corner and she was like, yeah, so carried on talking what she was on about before. And I was just like, what just happened? Like that was the coolest thing. Like was definitely fangirling very hard, just thinking, I just want to be you. Like that was so cool. The other thing about that placement and about doing the kind of obs and gynae in uni in terms of when we were having to study it is that it was the only thing that I actually wanted to read about. Like I found that it was the only subject that when I was on placement, like I was regularly wanting to Google stuff, like while I was there, like why does that happen, or what is that condition, or what does that mean? And I was wanting to ask loads of questions. And I think there were so many other specialties that I just couldn't care less, which is probably not the most professional thing to say. But I think realizing that it was the only thing I wanted to read about in my own time also kind of made me start to think, oh, maybe I should do this. So then I carried on with med school, finished fourth year, and it was getting to the final year. And we had at our uni something called an SSCP, so student selected placement, where you can kind of pick what you want to do for a placement. And I wanted to go back to obs and gynae. And the main, obviously I loved it, but I did also think, like when I reflected on that first placement, was did I just like love the drama? Did I like think it was really cool? Which is very different to could I do it? And you know, would I want the job of that reg? Would I want to have to make those decisions and have that pressure and responsibility, and also be able to kind of deal with the bad bits of the job? I think I was very naive when I first shadowed it. So I was like, I want to do it again. And this time I want to really try and think like, what's the job actually like? And I would strongly advise anybody doing that for any placement, especially if it's something that you've loved and are thinking, oh, should I apply to that? Is that what I want to do for my own career? Have a think about what are the bits you love about it, but also observe what the day-to-day life is like of the people around you. Ask them how they find work, what are the best bits, what are the worst bits, and just try and think, you know, would I want that to be my job role? From my SSCP, I went back to St Mary's and made like a few contacts. So I recognised a few faces from trainees from when I had been a student on placement there the year before. And I just asked them so many questions. I remember asking, one of the main worries for me for obs and gynae was, you know, will I be able to emotionally cope with things like stillbirth and miscarriage? And I remember speaking to one consultant about it and just saying to her, you know, like, how do you, yeah, like, how does that affect you? How do you kind of manage those situations? She said to me that everybody is different and everybody has their kind of thing that they find really hard to cope with. And for her, it was like elderly care and palliative care is something that she just knows that she can't face. But she can cope with the bad parts of obs and gynae. And that I kind of self-reflected, and I think I was probably similar to her. And there's a lot of situations that I struggle with, so particularly like pediatric stuff and like oncology and young people, like I couldn't do it. Especially like when I remember being on placement in oncology in uni, and that used to hit me so hard. I'm sat here now asking myself, would I ever be able to do the gynae oncology parts of my job? But the other parts I can cope with a bit better. So it was a useful thing to kind of have that discussion with her and have an open and kind of frank chat. And I'd encourage you guys to do that as well with trainees and consultants on your rotations. Have a think about what's going to be the hardest part of that job. And then don't just hear that parts are hard and go, oh God, that sounds horrible, I'd never want to do that. Ask them how they cope with it. Ask them if it's worth it in the end in terms of just the things balance out. So just ask. Put yourself forward as well. While I was there, they needed a fake patient for the prompt course, which is a mandatory course for anyone working in obs and gynae, which goes through obstetric emergencies. And they needed a patient for it. And I was like, oh yeah, I like put my name up. So I was like, well, I might look good in people's books and they might let me do more stuff. But I actually really enjoyed that because I basically got to sit in the patient bed and just like learn loads of obs and gynae while I just had a lay down. And watched all these trainees like flustered trying to manage the situation. So that was fun. And also you best believe that then was on my portfolio saying, oh yeah, I volunteered for this. But actually it was a very easy experience to kind of do. I also asked one of the consultants on that rotation if she had anything that she thought could get published. Just was a bit cheeky. Just said, just have anything that you think is publishable. You need someone to do the kind of groundwork for and do the kind of typey, hoping for a publication. And she said, oh yeah, we've got this case that we managed of this rare disease in pregnancy. I was like, fab. And she was like, oh well, I'll get the notes pulled and you can like write them up. And I was like thinking, this is my first publication, it's going to happen. But then like a couple of weeks later, she was like, I've had a thought, I think we should do a poster first. And I was like, okay, fab, sounds good. In my head thinking, oh, for God's sake. So I was like, fine, I wrote this poster and it got accepted to a national conference. Looking at it now, I had to go back through my things to find it. It's objectively a very bad poster. There's way too much writing and it's not very aesthetically pleasing, but nevertheless, it got accepted and it was also like 2018, 2019. So times have changed, but that got accepted to a national conference. And then I found out that in order to go to and present it, I had to pay a £500 ticket fee, which isn't discounted for medical students. And I spoke to the university and said, can I have any reimbursement? You know, and they said they'd pay for my train ticket to Edinburgh. So I didn't go, but I could still say on my CV and on my portfolio that I had a poster that I made that was presented at a national conference. It's still valid. You don't have to be there to present it. So again, don't be discouraged if you find yourselves in these like red tape situations. You can still say and put it on your portfolio and on your CVs. I then bumped into her like 6-7 months later on a placement of something else, and I said, oh, remember that poster? I said, oh, you mentioned that it might be a good case report. And she's like, oh yeah, I did. Yeah, you can just crack on with that if you want. So I wrote that up as a case report then. And then that did get published. But this was like, I think it was an FY1 when that actually finally got accepted. It wasn't, yeah, it was an FY1. So it was 2 years down the line, but it all came back to just putting myself forward on an SSCP in 4th year. And it was worth it in the end. And I would strongly advise, in terms of publications, a case report is such an easy way to go, because the consultant often, don't have the time to sit and go through and write it, but also they tend to be quite short. And if the consultant's seen a rare case, there's always a pretty much high chance it's going to be accepted. You don't need to do like a 10-year prospective study involving lots of maths and science. You can just write up an interesting case. So I strongly recommend doing that. Something to bear in mind is to look into which journals are free. So we submitted to BMJ case reports and it got accepted, but then it transpired down the line, although that's kind of technically a free journal-ish, that to stay as first author, you had to have an account with BMJ. And I worked at Tameside Hospital, which didn't have an institutional registration. So I would have to pay that fee myself. But if one of the other authors worked for Manchester Royal, one of the consultants worked at MRI, which did have an affiliation with BMJ, but in order to therefore get it for free, she had to be listed as first author. So I had to make that trade-off. Luckily, I had already started work by that point. I was an FY1 and could pick up a couple of locum shifts to pay that. And I took that kind of fall for it. But had that been in med school, it would have been a bit different. So it is worth having a look into what journals you can get stuff in for free when you're thinking about submitting stuff. Also, if anyone has any questions along the way, please interrupt me. I'll get sick of the sound of my own voice. And also, it's hard to remember at the end if you've got any kind of questions. So feel free to just pop your hands up or unmute yourself and ask away. So after that, I kind of just carried on with med school, to be perfectly honest with you. The only kind of extra thing I would say that I really did was some teaching for OGSOC, which is the uni's Obs and Gynae Society, just online Zoom teaching on different topics. And kind of once you've got a foot in the door with a society like that, like they'll often approach you to kind of give more teaching sessions. And that's a really good way to show commitment to specialty along the line. Like you're not just giving a one-off talk one time, because that doesn't have any weight in terms of interview and things like that. What you want to be able to prove is that you've done something over time and stayed committed to it. And that was, I think, one of the only ways that I kind of really did that, by doing those teaching sessions. In hindsight, had I been more proactive, having a role within that society would have been a really great thing to have been able to put on my CV or portfolio. I think I was probably just having too much fun at uni to do that. But I think, yeah, if it's something that's on your mind in terms of thinking, I really want to maximize my chances and have something that looks really good, that would definitely be something to look into. I also volunteered to examine lots of their mock OSCEs and things like that. And I've always loved teaching, so it was actually quite enjoyable for me. I think that's why it was the only thing I really carried on doing. Then when it came to finish graduating and applying for foundation training, I wanted to get somewhere with a track that had Obs and Gynae in, again, to see, can I actually do the job now? You can Google which kind of trusts have tracks that have Obs and Gynae in. I know that things have changed since I applied to foundation training and that it's very, very different now. I'm very much hopeful that that will change back and you guys will have more control over where you live and work. If you don't, even if you get randomly allocated to a deanery, you can still have a look at which trusts within that deanery have tracks in for Obs and Gynae and try your best to get one if you can. I don't know how much control there is kind of past that point, past getting into a deanery, because it has changed so much since I did it. But I'm hoping it will change back and you have more control. One thing with getting an Obs and Gynae job in F1 and F2 to think about is there will be lots of tracks that have an Obs and Gynae job in F1 and lots that have it in F2. And I debated for a long time about whether or not it was good to do it as an FY1 or as an FY2. As an FY1, I would say you're doing the job less. You're more supernumerary. So you're kind of less independently assessing those gynae patients and less independently managing those patients. However, you are often less busy than if you were to do it as an SHO. So I did it as an F1. And in hindsight, I'm really glad that I did, because I could often get the gynae workload done by 1, 2 p.m. And then I would just go and hang out on labour ward. I would go to C-sections. I would go and get taught, grab one of the regs or the trainees, and they just teach me stuff and we go through things. So I got to do, I think, a lot more of what I actually wanted to do because my role was less busy. As an SHO, you'd get the plus of getting more of a taste, I think, for what the job's like, but you'd have less chance and opportunity, I think, to just be like, oh, I want to go see that, so I'm going to go see it, or I want to go and learn about this, or watch that happen, or help out with that procedure. It's a lot more difficult to do that if you're managing the SHO workload. So this is my foundation training years. In terms of obs and gynae stuff that I did, I carried on doing teaching for OGSOC. I had to do prompt as part of being on obs and gynae, for even though I was just the gynae F1, but that went in my portfolio as well. This is when I also really started to realize that, I think obs and gynae is definitely for me, because before I was like, oh, am I making the decision too soon based on some exciting experiences, but this kind of job made me love it. So the group and the team were just the best. So they were all so supportive, they were all just so normal. And I think in lots of specialties, yes, we do kind of have a tendency to stereotype. But I do think that specialties attract different personality types. And once that kind of personality type is within a specialty, you're going to keep ending up with people who are attracted to that specialty because that's where they feel like they fit in. And I definitely felt like obs and gynae was where I fit in. I feel like there was less kind of hierarchy. A lot of people were very down to earth, but equally I found a lot of the regs and the consultants really inspiring, and just thought that I just admired a lot of them, and still do. But also everyone was so approachable, and I could just ask them anything and just have a joke with them and be very kind of unprofessional, actually, I think, with everyone. But I actually really like that. That's what gives me my job satisfaction now, as well as being able to feel like I'm at work with my mates. At one point I was worried that it was just that one team and I was going to dive down this career path and find out that actually I hate most of them, but it hasn't been the case. Everywhere I've ever worked in obs and gynae, it's been this kind of team. So I went back through my messages through the team, the group chat that we used to have when I worked there with some of the trainees, and found these messages. And when one of the consultants made a GIF of me coming out of theatre, having closed the sheath and skin after a C-section, I was so excited because I spent the whole placement learning how to do it. One of the regs had bought a grapefruit in for me to learn these types of stitches. And I was just so excited that I'd finished this C-section on my own, the end bit on my own. And I'll come back to that kind of later. Other things I did for my portfolio during that was be a member of the mess committee. I think the biggest gap in my portfolio and CV was leadership opportunities, and that's pretty much the only thing I could put down for it. So I think that's something to think about if you're still in med school and you're planning those next steps, is how can you prove leadership, because it's the part of most applications for fellow jobs as well. So have a think about that going down the line. And it was very little work actually for being able to fill a big gap in my CV. Then I went to New Zealand. I didn't want to train straight away. I wanted to have a bit more experience in obs and gynae. It's quite an intense specialty. When you first start it, I know, on personal reflection, that I'm the personality type that likes to feel like I know what I'm doing and have kind of lots under my belt before I feel like, oh yeah, I can do this. So I wanted to get a bit more experience, and I also wanted a break. I was the generation that graduated in COVID, and we started work 4 months early in the pandemic, and by the end of F2 we all needed a bit of a break. So I went to New Zealand. My sister and her whole family live out there. So my niece and nephew were there as well. So I lived with them for a year, and I worked in Obs and Gynae in Rotorua Hospital. Had a great life. It was really nice. I worked in Obs and Gynae for 6 months, and then I did a road trip for 3, and then I worked in rural hospital medicine. And the reason for that is when you apply to Obs and Gynae, if you've got more than 24 months experience, you can't apply at ST1 level. You have to apply as an ST3. And those places are like gold dust. And you have to work really hard to prove that you're competent of all the skills that would be expected you to have achieved in ST1 and 2, which is really hard. If you meet anybody that's gone into training at ST3 level, just do this to them, because it's so difficult to do. And I was thinking ahead in terms of, I wasn't sure what I wanted to do at the end of my year in New Zealand. I didn't know if I was going to stay there. I didn't know if I wanted to train. I didn't know if I wanted to do a fellow year. If I did a fellow year, I didn't know if I wanted it to be in education or A&E, because I was tempted by that for quite a lot of my life, or to do Obs and Gynae. So I kind of anticipated that I might do a 12-month fellow post of Obs and Gynae back in the UK. And so cut my Obs and Gynae job in New Zealand short to 6 months, so that I had the room to do that and still get in at ST1 level, if that makes sense. So I did, yeah, some rural hospital medicine as well, which again was really good experience, and it was closer to where I lived out there. So that was nice to not have a big commute. Other than that, in terms of that year in New Zealand, I didn't really do anything for my portfolio. I won't lie to you. I just enjoyed having a break, and I would definitely encourage that in others as well. Something to think about in terms of applying to specialty training is you sit the exam to get onto most specialties in January. So if you decide that after your F3 year you want to start training in F4, you're going to be revising for a big chunk of your F3 year. And I really didn't want to revise in my F3 year. I just wanted to relax. So just plan out in your head that if you also want to relax, then you're probably going to need to do an F4 while you get ready to sit the exam in January of the next year. So at the end of that year, I really wasn't sure if I wanted to do Obs and Gynae fellow or an education fellow. And ultimately I decided on education, mostly because I thought if I apply to Obs and Gynae training in that year and don't get in, at least then I've got an option to try and do an Obs and Gynae fellow afterwards. Whereas if I kind of had done Obs and Gynae and then got on, I'd essentially be doing ST1 twice, because a clinical fellow year in Obs and Gynae as an SHO is going to be it's going to be basically everything that you do in an ST1. So if you don't want to kind of repeat that, it's a good chance to get some experience in something else. And also you've still got the option then of doing it if you don't get into training first time. And I've always loved education. I've always loved teaching. So it was actually the best year. This slide makes it look like it was very academic. It wasn't. We just had the best time. But this is probably where I got a good chunk as well of what I was going to do for like interview if I needed to for Obs and Gynae. So I got my PG cert in medical education, and my job paid for that for me. I spent a large amount of the year revising for the MSRA exam, which is the exam that you have to sit to get into training, which I'll talk a little bit more about later. And I think the fact that I was doing that job is the reason I got a good score in that exam, because I wasn't balancing revision alongside a clinical rota. I've just passed my part 1 exam for MRCOG, and I do not know how people revise alongside working a full-time rota. It was 20 times harder than it was for me to prepare for the MSRA exam. So I think being able to be in a 9-to-5 job with it was non-clinical. I just taught med students Monday to Friday, 9 to 5. And that I was teaching a lot of the content that the MSRA exam covers. B, I could be at work and I had downtime to revise during my working hours. So I wasn't as wrecked when I got home and having to stay up late or anything like that. And C, I was just a lot less stressed and tired. So it's just a lot easier to revise. While I was doing that year, I also thought, what am I going to say at interview? if I get an interview for obs and gynae, what am I going to say? Because yes, I went to New Zealand to some obs and gynae, but didn't do much else in terms of things that look shiny on paper while I was there. So I reached out to one of the consultants at St Mary's and just shadowed a couple of shifts. Just went shadowed a labour ward shift, shadowed a night shift, shadowed some clinics and some scanning, which was really kind of them to facilitate. But if you don't ask, you don't get. Literally, I just said, "Can I come and shadow someone?" And they were like, "Yeah, sure, why not? Here are the dates that I'm working." And that for me was something that I would have been able to talk about at interview in terms of saying commitment to specialty and how do you know, is to say, in this job I've carried on volunteering to shadow these shifts to make sure, to learn about it and to stay in touch with obs and gynae while I was in my education year. And also I think doing a year of something else really stands out on your CV. I got another poster presented during that year as well, and got another publication as well, which again was basically just arts and crafts, but I made it sciencey. I made these kind of models to practice ultrasound cannulation on, and made it sound sciencey, and that got accepted into BMJ Innovations, and they have something called an early stage innovation report, so it's literally like 2-3 pages. Again, in terms of writing it up, not that difficult. Processes with publications are hard in terms of the logistics of the platforms that you have to use to submit everything, and getting reviewer comments back and having to make sure that you've addressed all of those and send them back. And it's kind of a laborious, quite a drawn out process that takes time, and you kind of want to just get your publication, but I'd plan at least 6 to 12 months in terms of thinking that you're going to go from submitting and having things teed up to getting your outcome and getting it published. But it is worth it. I also, and I would strongly encourage this, watch a load of the RCOG webinars because they're free, and they are actually interesting if you're a bit of a nerd in terms of gynae like me. Again, that looks good, and there's something that you can talk about and say that you've done with, which doesn't, take a lot of kind of effort, but it just proves that you're interested in it. They had one of their RCOG events as a careers webinar as well, for medical students and foundation trainees, which I went to and was really good. I think I did that one when I was in med school actually, but if you just go on there, if you just Google RCOG webinars, I think they do that one annually, so see if it's on there, and they record them as well, so you can watch that. And then I sat my exam in January, my MSRA, and passed and got into training, which I was very, very pleased about. So I'll move on to the application process. So once you've finished foundation training, well, in your F2, let's say you're applying straight from F2, you apply at the end of October on a website called Track, and it's a very anticlimactic experience applying for obs and gynae training on this, because you basically just put in your name and your date of birth and your job history, and then it's gone, it's done, and you're like, is that it? Because that's your application, essentially your initial one. You do that, it opens in October and closes in November. We've spoken about not having more than 24 months of experience. So one of the clinical fellows that works alongside me at the moment didn't get in this year because she had more than 24 months of obs and gynae experience, so would have to apply at ST3 level, which is a shame. And then in December, if you meet the essential criteria, which is basically you have a medical degree, you've not done more than 24 months, then you get invited to sit the exam. And then the exam is normally around the start of January. I started preparing for it around October, November time lightly, and then obviously ramped up the revision as I went. It's a multi-specialty exam, so you have to sit it to get onto most different specialties now. So I think even Gen Surg need it now. Psych, I think maybe need it. Peds doesn't. Peds doesn't? Can't remember. GPs do. It started off as a GP entry exam, but now lots of different specialties you have to sit it for. So it's on everything, and it's essentially like med school finals, but a bit more clinically applied. I set a Pearson VUE Centre, so it's online. It's nearly 3 hours long, so brace yourselves. but it is multiple choice and it's not negatively marked. So every cloud. You can sit it from overseas. So a couple of my friends in New Zealand, while we were working together, they sat it while they were out there. Now they kind of sat it for the sake of it. Neither of them got on because they hadn't revised because they were having fun instead. I think they just sat it to see what it was like. Because it's free as well, which is good. So you can just kind of sit it. But one thing to be aware of is this last year, they said to anybody that had applied for the kind of January start that because there was too many people sitting MSRA that year, that anyone who'd sat it within the last 12 months had to keep that score. So I would discourage you from sitting it for the sake of it, in case you get a bad score and they surprise you a year down the line by saying you have to use that one, you can't resit it. It consists of 2 papers. So one is a clinical problem solving paper. It's about 97 questions. And like I said, they're multiple choice. So it's kind of like, it's not all obs and gynae, it's any specialty. So there were some obs and gynae questions in mine, normally around like which emergency contraception would you say is first line? There's some data interpretation questions. There's, things about like Cushing's disease and all that stuff. So if you've just sat med school finals, you'd probably get a really good score. I used a lot of my med school notes when I was revising for it. There's lots of online study banks that you can use, which I used. MCQ Bank and also PassMed are both ones that I used. I think they're the only 2 I used. NICE guidelines, a lot of the what's first line and what investigations would you do questions come from NICE guidance. Asthma management is a big one, blood pressure management, diabetes management. If you know the NICE guidelines on those, you'll get those answers right on MSRA. They do provide a couple of past papers as well. And then also kind of having experience. Honestly, I think having taken that time out and worked clinically for a bit longer, a lot of the questions I could answer because I'd done it at work. I knew about patients like that from work. So I definitely think that helped. The second question is what basically used to be a situational judgment test. I know that some universities are getting rid of those now. Everybody is different in how they feel about those. I personally feel like can't revise for them. Certainly for MSRA, I didn't revise for it. I tried to for about, I think, 2 hours and just thought there's no rules to this. They're making it up. I'd rather spend the time trying to maximize my score in the clinical side. So that has less weighting in the exam. It's less questions and less weighting. If you're the type of person that likes to prepare for that, then do, but I didn't gain anything by trying to figure out their made up rules. Results come out in February and there's 3 outcomes. So you're either not successful, or you get offered an interview, which happens in March, or you bypass. And that's a new thing, which is where if you score highly enough in your MSRA exam, you bypass interview and get straight onto training. And you also get preference, you're therefore ranked in terms of rankings and of applicants above anybody that's interviewed as well. So you get more control and more choice over where you go for training. Luckily I bypassed, and I think it was because I was in my Ed Fellow year when I was revising, but I had done interview prep. So when I was shadowing those shifts at St Mary's in my Ed Fellow year, one of the consultants I worked with, she actually sits on the interview panel, and we had a meeting and she just basically told me how the interview runs, her top tips for it. We actually did have a mock interview scheduled before anyone bypassed. So all of those things were just like out of the goodness of her heart. But they're kind of ways you can get a foot in the door. The interview happens online. Some things that you need to kind of think about are proving commitment to specialty. There's also a section of it which is, so basically it's 2 sections. There's one on clinical prioritization where they give you a list of scenarios and say which patient would you see first and why, and how would you manage these patients. And it's not obs and gynae. It can be some obs and gynae stuff, but it doesn't have to be. It can be general medicine, gen surgery. Basically anything you should have covered in F1 and F2. And then the other half is like a panel with questions. So they ask about commitment to specialty and understanding of the curriculum and those kind of things. So then after that, you find out where you've ranked in terms of all the applicants. And then you choose your kind of preference, your deaneries. And then once you get a deanery, you preference your hospitals. For obs and gynae, you get your ranking bears weight on where you get for ST1. But once you're in training, you re-rank you basically each year you say what your top 3 would be to go to, which hospitals will be your top 3 to go to next. But your rank doesn't have any influence on that anymore. So it's only for where you get for ST1 that your rank has influence for. Once you're in, you say your top 3 and you have to give an educational reason of why you want there. And they don't have to give it to you either. Which sucks a little bit, but here we are. So in summary, things that you can do at an undergraduate level and postgraduate level, which aren't that hard, but still look very good on paper, is getting involved in societies, be that just teaching for them, volunteering for their mock exams, even as patients, volunteering as a patient. If you can, and you've got the get up and go that I clearly didn't have, then having some sort of role within a society as well. Teaching, shadowing shifts. So even if you're not on that placement, you could even, like if you're on obstetric, if you're on anesthetics or something, and you want to do obs and gynae, say to your anaesthetist, do any of the anesthetic team work on labour ward a lot? Can I have a day where I go and work with them instead? That's fine to ask. If you're on peds and you love O&G, ask to stay with the on-call team when they get called to the Cat 1C sections, and then when you're there, have a chat with all the trainees. You can kind of find a way to keep your foot in the door. If you're in a completely different job like I was, just email them, just ask and say, oh, I remember I worked with you. I remember, I was on that placement with you that time. I'm currently on a different job, but do you mind if I just come and shadow some of your clinics or shadow some of your shifts? Publications we've spoken about, so case reports, journals that have kind of shorter article styles as well are great. And there are some free ones, there are some that have kind of very little gatekeeping as well. So just kind of be tactical about what you want to write up and how you want to submit it, especially if you're towards the end of med school or you're in FY1 at the moment and you want to count for application this year, you're tight for time. So try and find somewhere that has a quick turnaround and is a short paper, rather than getting yourself into some audit cycle or quality improvement project that has 20 runs or prospective kind of data collections before you have a chance of publishing. Audits and quips, you have to do as part of foundation training anyway. If you can try and do them in something obs and gynae related, that's great. But, a lot of things as well can still apply to obs and gynae. I did do one in O&G, and then I did an education related one while I was on O&G, and then I did an orthopedic one. Everything still looks good on your CV though. Posters as well, submit posters anywhere. You can make them on Canva in like a couple of hours. So if you've done some, if you guys are doing any teaching, get pre and post session feedback and try and, see if there's anything meaningful there that you could wrangle on a poster somehow. I think OGSOC, so the Obs and Gynae societies, have conferences as well for students. So anything you do, just think of a clever way you can twist it and make it into a poster, and just try your luck. Just submit it, and if what's the worst that can happen is that they say no. The best that can happen is they say yes, and you get to put that on your portfolio. Attending webinars and lectures, like we said. Reflective practice, I think, is really important in kind of general, but especially for kind of applications and also interviews. So I've been an interviewer for the job that I had previously for the people who kind of applied to take over from us. And I also have interviewed for other processes as well. And a good answer is never a superficial one. If someone says to me, yeah, I've got 4 publications in the British Obs and Gynae journal, or I have performed a skin to skin cesarean section when I was a first year medical student, like we don't care. If you can say what you learned about it, if you can actually think critically about it and go, and actually in hindsight, that probably wasn't a very good thing to do, like medico-legally, or, like knowing your boundaries is really important. Maybe I shouldn't have done that. And what did I learn from that experience? And that's what matters. If you said, oh, I did a publication, and actually, honestly, what I learned from the process is that there's a lot of red tape, and that the process is quite long and drawn out, and we don't really get prepared for it in medical school. And I think that's a gap in our training in terms of preparing us for building a competitive portfolio. That's interesting. That stands out. That's a good answer. So reflect on everything you've done. And that's what I say as well, is maybe more so for obs and gynae, because I know there are some specialties that are very much points based. Like you, when you submit your application, you get points on how many publications you have, you get points on how many audits you've done, points on how many, you know, teaching sessions you've done. O&G isn't like that. For specialties like that, yeah, on paper, superficial, that you get the benefit of that. But anything at interview or anything that isn't points based, being able to give that and reflect on experiences is a much better thing than being able to list 25 things that you've done. So I think there's a lot of medical students that place a lot of pressure on themselves to get kind of all these fancy things written down on their CVs, but don't panic if you haven't done that. Don't panic if the things that you've done superficially look a bit kind of maybe less impressive at a surface level, because if they may look less impressive on a surface level, but you've reflected on it and have learned from that experience or can talk about it and make it sound good in an interview, that's of way more value. So don't panic and don't ruin your whole uni experience by just trying to build a CV. Make sure you have time to enjoy yourself as well. Extracurricular stuff as well. I think we'd sat and listened to loads of people apply for this job and we were getting a bit bored, and then one person was like, oh, I run a raft making society. We like teach people how to make rafts, and we were all like, oh my God, that's amazing, tell us more. Again, like, it's completely different, but it made that person stand out and we were really interested, and a lot of the things that they learned in that role, what you could see would make them good at the role that we'd done. So keep up with your extracurricular stuff, because you enjoy it should be the main reason, but also I'm sure there's a way that you can spin it at interview. Part 1 exams, I know that there's a trend towards people sitting the Part 1 exam for the specialty they're trying to get into. So a couple of the fellows as well that I work with are going to sit the MRCAG Part 1, even though they're not trainees. I personally feel like you shouldn't have to pay £500 for an exam that after which you still might not get accepted into that specialty. I don't think it should be based on that. I think it should be based on what you're like as a person and what you're like clinically and what your merits are, rather than can you pay £500 to sit an exam. If you are panicking that you have nothing else and you have the means to do that, then that's your kind of prerogative. Again, I think because obs and gynae is interview based, I think it interviews someone saying, oh, I passed Part 1. Yes, that shows commitment to the specialty. Obviously, you know, you're sure you want to do it. But if someone else has done some like volunteering for something completely different and has learned loads about it and can talk about it, and that's developed them as a person, I'd rather them get in. That's a better interview answer than saying, yeah, I sat and passed Part 1. But I know that a lot of people are starting to do that now. Other main advice: put yourself forward, just be cheeky, like don't be shy. I think 99% of everything that's on my CV has come from me just asking someone nicely, like, oh, like, could I, like, please, and be enthusiastic. People want to reward enthusiasm. Like when I have medical students on placement that are keen, I just want them to be able to do everything and see everything. If I have a project, I want to be able to put their name on it, you know? So be enthusiastic, like show that you're interested. If you have a day where you feel like you're not, fake it, and just be cheeky and ask for those opportunities and put yourself forward for things, because again, the worst that they can say is no, and you'll find that most of the time people say yes because they want to reward that enthusiasm. Find a specialty. So I know a lot of you, I imagine, are on this because you want to do obs and gynae, where the kind of good outweighs the bad. There's no job that doesn't have bad stuff, and there's no job that doesn't have a downside. You need to find one where the highs of it for you personally outweigh the lows. And that might be in how frequently you get good bits versus bad bits, or it might be in the weight of the good bits versus the bad bits. But find that works for you, and don't be put off. Firstly, don't be put off by people talking about obs and gynae and going, oh my God, I can't believe you do that. Like, it's awful, it's horrible, da da da. Everybody's different, and that's the best thing about it, because I can't imagine anything worse than sitting in a room on my own in a job. That's my worst nightmare. Even though I might have a nicer lunch break and I might, you know, finish, you know, sooner and work less nights, I'd be less happy overall. Because for me, O&G is what gives me my kind of like fulfillment at work. Like I get fulfillment and job satisfaction from doing the role that I do now. And if everybody loved to do the same thing, that wouldn't be the point. So don't sit and listen to somebody saying how awful obs and gynae is when it's not something that they enjoy. Obviously, they're going to say it's awful. It's not awful if for you love it. So therefore, all the bits that they are saying are bad are far outweighed by the fact that you love it, and there's so many great things about the job. So I would, yeah, go like this when people start to say horrible things about obs and gynae training. Also, don't be put off. I know that there's a lot in the media now, and it is true that it's getting harder to get into training. The competition ratios, particularly for obs and gynae, have ramped up recently. Someone's got to get in, so go for it if you want to do it. If you don't get in, don't see that as a bad thing either. I didn't choose to apply straight away after foundation training because I wanted more time, but I'm so glad I did. And one of the reasons that I did that is because when I was a med student on that SSCP and when I was a gynae FY1, I asked all the trainees, what do you reckon about taking time out and doing an F3 versus starting training straight away? And that everyone said who hadn't taken time out and done time afterwards said, I wish I had in hindsight. So I took that advice and went with it, and I'm very glad that I did. But that decision, you can see, was influenced by the teams that I worked with beforehand. So if you don't apply and don't get in, don't see that as just a negative. Just think, oh, now I've got a year to do something else fun in the meantime. And I also think, like I said before, obs and gynae, no specialty is easy, and every personality type is different. But I definitely like to feel quite comfortable with something in order to get a lot of job satisfaction. I have to feel like I'm good at it to get that feeling at work of enjoyment. And having built that experience beforehand made me start O&G. I wasn't scared. I knew what all the acronyms were. I knew what the drug names were. I roughly knew what people were on about when they're talking about management plans. And that, I knew how to assess a gynae patient. And that for me made me just enjoy it from the off. One of the other ST1s that I know had never done obs and gynae before and just went in. And I know that for her was a really daunting experience and quite a steep learning curve. And she still enjoys it. She loves it and probably is a different personality type to me and is okay with that. But I know that I'm not, and I definitely appreciate that experience, that prior experience when I started. And yeah, you don't have to be a scientist to get published. You can find kind of cheeky ways to get around it. I would say publications is less about kind of knowledge and science and statistics and more about resilience and patience in terms of how long and drawn out and annoying the process can be. But it's more frustrating than it is hard. So just get the ball rolling, get it started, and just stick it out because it'll be worth it when you get published. That then is on the right. I messaged the same group chat from before. I sent them a screenshot of when I first closed the skin after a C-section. And then this year, my friend who had been on the group chat at the time as well recorded a GIF of me after I did my first C-section on my own last year at the start of ST1. And I sent that to the same group chat and said, I've upgraded my shimmies from closing the skin to doing the whole C-section myself, which was a nice moment. I said in 10 years' time, I'll do a complex surgery and send them all a shimmy GIF. And one of the ST6s replied, it better not be 10 years. But, I like to take my time. So thank you very much. I hope I've not bored you to death and I hope you're not sick of my voice. I know I'm a little bit sick of mine. Please ask any questions you want. No questions silly. Just go for it.
Well, thank you very much for that, Alice. We do actually have some questions in the group chat. I don't know if you want to have a look.
Just to lead it past to be relevant to the specialty sports club. Great. Yeah, no, it doesn't have to be relevant to the specialty at all. It's what you learn from it because it's applicable to anything. Obs and gynae training will teach you how to be an obs and gynae doctor. You don't need to no one's expecting you to start obs and gynae training having the leadership skills you need to manage a massive postpartum hemorrhage. What you need is that being able to communicate with a team, being able to think about people's strengths and weaknesses in a team and kind of utilize those. Any kind of skills like that you can get from anything, it's applicable. And it looks good. And also I think if you've got something a bit different, then it makes you stand out as well. So absolutely doesn't have to be relevant. We're sure to get involved with OGSOC if you're placed in a base hospital that's further out. Not sure, ask OGSOC. I wasn't even a member with them at all. I ended up doing like, I don't know, like 50 teaching sessions or something silly for them over time. Like literally just email them and say, look, I'm in Preston. But like, do you have any online teaching or anything? It was all on Zoom, the ones I did. So just drop them an email and say I'm in Preston, but is there any remote stuff that I can kind of get involved with? Just put yourself forward for it. Oh, thank you. Is there a maximum time you can apply for training if you don't get in first time? That's a great question. I don't know. I don't think there is. I could be wrong though. I'd have to Google that one. Sorry. How do you and others you've met find the work-life balance as it is a more intense specialty? It is a more intense specialty. And the work-life balance is hard. I like having days off in the week though, like midweek days off. Like when I was in my 9 to 5 job Monday to Friday, I found it really hard to get to the post office and to my own GP. So I actually really liked being back on a clinical rota in that perspective. I would also say it's kind of overall job fulfillment. Like yes, if your rota's busy and you're in work more than you're out of work a lot of the time, if what you're doing at work like kind of feeds your soul and makes you feel good, and is you're doing what you love, then it's kind of worth it. What I would say is if you start to kind of tire out or burn out, so many people go less than full time now, and you don't need a reason. I think it used to be that you basically had to be like married with children and be like, I need to look after my baby. Now you can just say, I want to go less than full time, and they'll let you go less than full time. You can go less than full time and still do the full on call rota, so that most of your shifts tend to be on call rather than normal days. But that affects your training duration and you pay a lot less if that's something that's on your mind. So yeah, I would say overall choose what's going to make you kind of happy. And if you love O&G, then and you love the work, then that's kind of worth it. And most of my friends that are struggling with work-life balance is because they've not found a specialty that they love. So for them, being in work is a job. They go, they get it done, they get paid, they go home. When your work-life balance is off and you're in work more than you're out of work, or you find that your rotas, do long hours and frequent nights and things, when it's a job like that being there doesn't give you anything back, that's massively impacts your life and that balance. So I think if you found something that you love, then do that. Would it be better to do some kind of job in F1 or F2? Yeah, like I mentioned, it depends. For me, I'm glad I did it in FY1 because I had more time to just go to stuff I wanted to go to in terms of like I could finish my job load sooner, and then just go and hang out on labour ward, or go to theatre and see the gynae surgeries. But as an if you do it as an FY2, I think you'll get more of a taste for what it's like to actually do the job. So again, that's kind of personal. It doesn't make any difference in terms of your application. In terms of if you were to mention it in an interview, I think just the reflection on your time in that role, whether you did it in F1 or 2 would be enough. They don't care that you've not done it as an SHO. No, I didn't intercalate and I didn't do any other degrees, just had a nice time. And I don't think I want to do kind of research or anything either later down the line. That's just not the way my brain is inclined. I'm not very sciencey. But Obs and Gynae certainly has a lot of opportunity for research and for doing other degrees during training, if that is something that floats your boat. Could you clarify what you did after F2? So after F2, I did a year in New Zealand, where during that year I did 6 months working in Obs and Gynae, a 3-month road trip, and then 3 months working in, no, a 1 month road trip, one to 2 1 and a bit months road trip, and then 3 months working in rural hospital medicine. Then I came back from New Zealand and worked as an education fellow at MRI, Manchester Royal full-time. So it was non-clinical, Monday to Friday, taught the med students. During that year, I wrote an Obs and Gynae OSCE station, which got added. I did lots of Obs and Gynae teaching, examined the OSCEs, I was an OSCE examiner for all of them. But obviously, had I had an interview, the one I would have spoken about is examining the obs and gynae OSCEs. So yeah, that's what I did. And then after that, I started ST1. You guys, and thanks everybody for coming, especially on a sunny evening, which is rare, isn't it, in the UK? But appreciate it. And I hope you all get on to obs and gynae. I look forward to working with you all in future. See ya.